the adult recommended core clinical quality measures. I put emphasis on the word recommended because although they do recommend you select those adult core reports, you do have the option of selecting any 9 of the 35 clinical quality measures available in ClinixMD for your reporting this year, especially if there are those that are more relevant to your scope of practice and your patient care. To start out, I will be taking you to the 2014 Clinical Quality Measures Report dashboard, available under the Reports menu. You can also set up links for them in your toolbar right here under your user preferences. The information we will be covering today is available under the Help menu in ClinixMD in the Meaningful Use Stage 2 submenus. Under the Meaningful Use Guide, you'll see a separate link for the 2014 Clinical Quality Measures. We have provided both a written guide that details the information that is being tracked in each measure and where it is documented in ClinixMD. We've also provided the Clinical Quality Measure Specification Sheets that have been distributed by CMS so that you may use them and better understand the data that's being tracked in these clinical quality measures. The information including in these spec sheets are the clinical rationale, the body that came up with the measure, or the measure steward as it's known, the clinical recommendation statement, and the improvement notation available. For instance, that a higher score indicates better quality care, or a lower score or percentage indicates better quality of care. Some of these measures are directly from the American Medical Association. Some are being governed by the NCQA. You'll notice that there is an overlap between the clinical quality measures and the PQRS measures. For 2014, they aligned the two programs with the specific file format that is generated in 2014 certified systems, so that you may use both the electronic file format known as QRDA. You may use that for both your clinical quality measure reporting component of the EHR incentive for 2014, and also use the same files for your PQRS reporting. To do so electronically, you would log into the QualityNet Physician Quality Reporting System portal and upload the same file for both quality reporting incentives. At the time of attestation, what you would do is indicate that you're going to report your clinical quality measures along with your PQRS measures. You will then be allowed to continue with your attestation of your results for your core and menu set measures. Then you will log into the PQRS reporting portal known as QualityNet by the end of February of next year, 2015, and report both your clinical quality measures and PQRS measures together through a batch file upload. They will then, the two systems then communicate, and they show that they've received the required number of quality reports for both programs. They will then assess for payment for both your incentive, EHR incentive program, and also the PQRS incentive program. So it will delay your EHR incentive payment if you choose to do that method. Now, to backtrack, as I mentioned, there are the specification sheets available under the Help menu in ClinixMD for you to review for each measure. These specification sheets look like this. You'll notice the measure title at the very top and the measure identifier, the CMS number. Continuing on, it gives you the clinical rationale, any clinical recommendation statements, the improvement notations, and then goes in to describe in detail how the initial patient population and denominator is tracked, and what the numerator is in terms of this report. The supplemental data elements that it mentions are the same for every measure, and the information being tracked is payer codes, race, ethnicity, and sex of all your patients in the report. The payer codes that I mentioned are attached to your insurance master list under Settings and Health Plan. This step is required if you're going to be electronically filing your clinical quality measures and PQRS reports via the QualityNet portal. This is how they identify Medicare and non-Medicare insurance types in the data that is submitted. So for your insurance master list, under here in the Insurance tab, each insurance is listed at the top, and down below are the details section for that payer. And you'll notice that there is a drop-down list available. Click this list, and you will be able to select the specific payer code. As you can see, it's broken out by Medicare and Medicare subcomponents, such as Medicare HMO, PPO, managed care, medical savings account, drug benefit, Medicaid plans, TRICARE, other government insurance programs, and then also your commercial codes. Okay. As you can imagine, there is no consistency across the board of how this information is listed in practice management systems which interface with ClinixMD. So there's not an easy way for us to automatically identify these specific payers just by name alone. We can identify quickly by a name if it's a Medicare managed care plan, or the Part D plan, or if it's a PPO plan. But this step is important if you're going to be electronically filing your CMS clinical quality measures and PQRS measures by the QualityNet portal. If this information is not included, the file will be rejected. It will fail when it is analyzed. Okay. Returning back to the specification sheets, there's also another feature I'd like to point out at this time, and it's available in each one of these specification sheets. Is a section called Data Criteria Elements, QDM data elements. And it's breaking out by value sets how each piece of the information is being tracked, specific code sets that go along with your specific numerator and denominator elements. For example, the numerator for this measure, which is closing the referral loop and indicating that you've received consultation reports for your patients that you're referring out. The numerator is tracked by occurrence A of intervention performed referral. You'll then notice down here below that there is a specific data element that corresponds to that with a specific value set, and they're all identified by a string of numbers. I point this out because you can look up the data sets in ClinixMD via this value set search tool we've provided. Simply put in the measure number, and you can cut and paste that value set ID, click search, and in this case, the referral reports are identified by 3 SNOMED codes. In ClinixMD, when you're tracking the receipt of a consultation report from the specialist during your referral out process, there are 3 descriptions available for you to select from. They tie into these SNOMED codes in our data tables for tracking this measure. Okay, so moving on, we're going to go ahead and start out by reviewing our first adult core measure, which is CMS 50, closing the referral loop, receipt of specialist report. It's also PQRS number 374. The numerator are the number of patients in which you have indicated you have received a consultation report back after a referral. Okay. This information is tracked in the encounter using the Refer/Transfer tab that was added in our 9.0 release. You'll notice that you can use it for both inbound and outbound transfers and referrals. There's a newly added tab here called Refer/Transfer. And to do a referral out, you would click the Add button. It automatically selects the Referral Out radio button, but you can also select Transfer Out. Both qualify for this measure. Select a provider from your external provider list. If you've set up a direct message address for them in your external provider master list, it will also be displayed. And that lets you know you can also utilize the electronic sending the summary of care record to send that information to the specialist. If you do not have the applicable provider listed in your external provider list in ClinixMD, you can also free text the name in this field. The default date used will be the current date, but this can be changed by selecting the calendar. Indicate the type of referral. Again, this is a defined list by CMS that's been provided. Okay? So that is your indication that the patient has been referred. To notate when the consultation report is received from the specialist, you would simply mark the received checkbox in the record, and it defaults to clinical consultation report, which is one of 3 codes in that value set list. You may also select from one of these 2. Okay. Now, to track these referrals, since you won't know readily on a case-by-case basis who has been referred out, we have created a pending referrals tab in the office area that you can use to manage your referrals in your practice. It defaults to your outgoing referrals for a specific provider, but you can choose another provider. It defaults to your current one, or you may select all providers. You can further narrow it down to tracking referrals out to a specific provider, or you may check referrals for all providers and click Search. All your outbound referrals are then displayed. Now, to complete a referral, even an enclosed encounter, simply select the patient's name and click Complete Referral. And it takes you straight to the encounter, to the Refer and Transfer tab for that referral. And at that point, you would just simply mark the checkbox that it was received. If the encounter is closed, there's an Edit button to the right of the Print button that's available. All you need to do is click that button to indicate you want to edit this tab and mark the Communication Received box. Again, it's a simple checkbox, and it defaults to the current date and time. Okay. Next measure is CMS 165, PQRS 236, controlling high blood pressure. This is the percentage of patients aged 18 to 85 years of age who have an active diagnosis of hypertension, whose blood pressure is adequately controlled, which is defined as less than 140/90 during the measurement period. Your measurement period will be your report period for this year, which will be Q4, October 1st through the end of the year. The clinical rationale behind this measure is the prevalence of hypertension in the United States and the approximate 50 million or more Americans that have high blood pressure that warrant some kind of treatment. The United States Preventative Services Task Force recommends that clinicians screen adults age 18 and older for high blood pressure. And of course, the most frequent and most serious complications of uncontrolled hypertension include coronary heart disease, congestive heart failure, stroke, renal disease, retinopathy, etc. In this case, a higher percentage indicates better quality of care. The denominator for this measure are your patients that are 18 to 85 years of age who have an active diagnosis of hypertension within the first 6 months prior to the beginning of the report period. Exclusions that are automatically calculated for this measure are those patients with evidence of end-stage renal disease, dialysis, or renal transplant. Patients that also are pregnant are also excluded from this measure. The numerator are those patients whose blood pressure at the most recent visit is considered adequately controlled, which is a blood pressure reading of less than 140/90. Pretty straightforward on how this measure is tracked. Of course, your diagnoses are tracked in the Diagnosis tab or in the RxDX List tab in the Problem List window. Blood pressure is then recorded in the Vital Signs tab, specifically your systolic and diastolic readings. Moving on, the next measure we're going to be covering is CMS 166, which is also PQRS number 312, the use of imaging studies for low back pain in adults. This is the percentage of patients 18 to 50 years of age with a diagnosis of low back pain who did not have an imaging study, such as a plain X-ray, MRIs, or CT scans within 28 days of the diagnosis. The clinical statement and rationale behind this measure is that low back pain is a pervasive problem that affects 2/3 of adults at some point in their lives. It is the most common musculoskeletal condition, and it affects approximately 31 million Americans, and is the #1 cause of activity limitation in young adults, and is responsible for the direct health care expenditures of more than $20 billion annually. The clinical statement behind this measure is that clinicians should not be routinely obtaining imaging or other diagnostic tests in patients with nonspecific low back pain. And its purpose is to reduce unnecessary imaging unless red flag indicators exist. The improvement notation for this measure is that a higher percentage indicates better quality of care. So the number of patients without imaging performed indicates better quality of care. The denominator for this measure is patients aged 18 to 50 years of age with a diagnosis of low back pain during either an outpatient visit or an ER department visit. The exclusions for the denominator automatically calculated are those patients with an active diagnosis of cancer at any time in their history, or those with a recent diagnosis of trauma, IV drug abuse, or neurologic impairment during the 12-month period prior to the visit. The numerator are the patients without an imaging study conducted on the date of their visit or in the 28 days following the visit. In ClinixMD, this information is documented by diagnosis, either in the Diagnosis tab or in the Patient's Problem List, recorded in the RxDX List tab. And radiology orders are tracked through the order entry process with the subtype of radiology. And it's identified by the LOINC codes that you attach to your radiology orders. If you recall, this was covered during the initial administrator setup webinar that we hosted back in August. For those who missed that webinar, it is available under the training menu in ClinixMD. Okay? In brief, you set up those LOINC codes, which are identified in the value sets that you may look up in ClinixMD. You attach those to your radiology orders in Clinic Setup. If using that value set search tool and you know the LOINC code you want to use, simply enter it in the LOINC field to the right of the radiology order name. Or you may utilize the search tool that's available in ClinixMD by clicking the search icon and typing by description. Okay? So this measure directly looks for specific LOINC codes attached to your radiology orders. Moving on. The next measure is CMS 156, which is also PQRS number 238, the use of high-risk medications in the elderly. There are two patient populations being tracked in this report. The percentage of elderly patients who have at least one high-risk medication, and those percentage of elderly patients who have at least two different high-risk medications. So there's two groups you'll be reporting on for this measure alone. It specifically tracks the percentage of patients 66 years of age and older. The list of medications that are considered high risk as identified by the NCQA are available in that value set search tool. You would look up the value set ID for high-risk medication orders in that specification sheet. And it displays the list of the high-risk medications being tracked in this measure. Okay? Any one of these medications assigned to your patient will qualify them for the numerator in this measure. In this case, the improvement notation is that a lower percentage indicates better quality. Those medications are tracked via entry in the Prescription tab in an encounter for new prescriptions, and also those that were previously entered and are listed in the medication list in the RxDX List tab in the encounter. The next measure is CMS 69, PQRS number 128, Preventative Care and Screening, Body Mass Index Screening and Follow-up. This is a carryover from the original clinical quality measures that were introduced in the Stage 1 portion of meaningful use. 2 rates are tracked. Patients 18 to 64 years of age with a normal BMI, which is defined as 18.5 to 25, and patients 65 and older with a BMI outside normal parameters, which is defined as 23 to 30. If it is outside the normal ranges provided, it's looking to see if a follow-up plan is documented during the encounter or during the previous 6 months of the encounter during the measurement period. And information is tracked in the Vital Signs tab. It will automatically calculate the BMI from the height and weight entry of your most recent visit if nothing is documented in the current visit. So this is the BMI as of his last visit, and will be updated automatically based on new entry. In this case, the patient's BMI is now 32.55. For this 38-year-old male patient, this BMI is considered outside the normal range. So to document your BMI follow-up, click this BMI follow-up button. This has been here since our initial 8.0 release in 2011. And the change that was made is that there is now a discrete list of follow-up options that they're looking for. All you need to do is select one of these responses. The nutrition and physical activity drop-down lists are strictly used for your pediatric patients for the corresponding BMI measure for adolescents. You do not have to do these unless you so desire for your adult patients. This note field is optional, and it's free text entry. Click OK to lock in your documentation. In this case, the improvement notation is that a higher score indicates better quality. And this is to address, the purpose of this quality measure, is to address the obesity epidemic, quote unquote, that is a growing concern in the United States and has been identified as a cause of concern by the CDC, the Centers for Disease Control and Prevention. It's been also shown to reduce life expectancy by 6 to 20 years depending on age and race of patient. Patients with BMI outside those normal parameters should be offered or referred intensive multi-component behavioral interventions. Moving on. The next and final adult recommended core measure in ClinixMD is CMS 138, PQRS 226, Preventative Care and Screening, Tobacco Use Screening and Cessation Intervention. This is another carryover quality measure from the original Stage 1 quality measures introduced in 2011. The information is still tracked in ClinixMD in the same manner. Smoking history is documented in the Medical History tab in the Substance Abuse pane. Check the box to indicate that you discussed smoking history with the patient and identify their current smoking status. This does not have to be documented at each and every visit. There are a couple of new smoking statuses that have been added for the 2014 clinical quality measures, and those are light tobacco smoker and heavy tobacco smokers. If your patient is an admitted smoker, you then document any recommendations provided by selecting from the list here. Any one of these are relevant. You may either use your clinic design list, which is populated as part of the original 2011 measures, or the additional cessation measures that were added as part of the 2014 clinical quality measure specifications. In this case, the improvement notation for this clinical quality measure is that a higher percentage indicates better quality. Not necessarily the higher percentage of your smokers, but the ones that you're giving cessation intervention to. The denominator is your patients that are 18 years and older with no denominator exclusions. And your numerator are patients who are screened for tobacco use at least once within 24 months and receive tobacco cessation counseling if identified as a tobacco user. There are denominator exceptions available for this measure, which are different from denominator exclusions in that it's recorded on a case-by-case basis as it's relevant for each patient. And that is any documentation of medical reasons for not screening for tobacco use, such as limited life expectancy or other medical reasons. So that would be on a case-by-case basis. I'm now going to open this up for any of your questions that you may have. In your GoToMeeting menu on the right side of your screen, there's an option to enter questions. Go ahead and add any question you have in the box that's provided and send to me. And I'll give you about 5 minutes to get those questions in there, and I will answer them one at a time. Okay, well, it looks like we don't have any questions today, so that concludes our webinar. If you have any questions for me, please feel free to send them to me via email. I can be reached at mary.brunson@clinicsmd.com or via our support email, which is mdclientsupport@clinicsmd.com. All of these videos that we've been hosting will be available under the Help menu in ClinixMD under the Training submenu. They'll be available shortly, okay? Thank you all so very much for attending today's session, and I look forward to hearing from you guys again. Thanks, and have a great day.